Really happy to be here to support the great work that you guys do, and of course, growing up through residency here in Toronto, I heard of many of my mentors, Michael Jewett and Alex Lada, Rob Nam here at Sunnybrook, Laurie Klotz, all of whom supported your work, and I'm happy to do the same as well. I want to talk about basically advanced therapies, new therapies in bladder cancer. But we'll kind of step back at the beginning and really look at an overview of how we diagnose bladder cancer right from the very beginning, and what's important in how we risk stratify patients and really determine the type of aggressiveness the tumor has and how we match treatment accordingly to that. Okay, and then I want to really focus on radical cystectomy and talk to you about minimally invasive approaches to radical cystectomy, and that's really going to be something that's going to be at the very forefront in the next 10, 20 years, and it's something clearly on the horizon. And then we'll have a question and answer period at the end. I'm more than happy to be interrupted, so please free to stop me if you have any questions. Okay, just getting back to the basics. What is cancer? What is bladder cancer? A simple definition is that these cells, we've got various cells in our body. They perform a specific task. Okay, and cancer is a disorder growth of any group of cells, and this is a very important framework that we think about as oncologists. What really drives a cancer cell? Okay, so it's really the mechanisms that are being turned off that would normally keep it in check, and then somehow it's also turning on a lot of other mechanisms that allow it to grow faster, evade other mechanisms that keep it in check, like the immune system. Other important factors include growing blood vessels that really help it propagate and move forward. How does it actually move out of the organ? It acquires the ability to metastasize, to spread to other sites. So this is really, features that are unique to all cancers, and we often have to think about the specific cancer that we treat and targeting different aspects of this. So this is really getting at the biology of cancer, because that's where we all come back to at the end of the day, right? So bladder cancer itself is abnormal growth in the lining of the bladder, and that lining is called the urothelial layer, okay? And that gave rise to the term urothelial cancer. So when you're talking with your oncologist or urologist, the bladder cancer is synonymous with urothelial cancer, and an older terminology which is still interchangeably used is transitional cell carcinoma. So they're all somewhat equally used, but the scientific terminology is urothelial cancer. The other important thing to note is that the same lining that lines the bladder lines the whole tubes all the way up to the kidney. So those are the two tubes, the ureters that drain the kidney, and where the urine collects in the kidney is the same lining. Okay, so the kidney, the urine pools in the kidney and comes down the tubes into the bladder. So that lining is all contiguous and the same. And it's important for us to think about that all the time, because the same risk factors that one might have for having cancer in the bladder could potentially affect the lining all the way up. So we're always worried about what's going on elsewhere as well, and that is important in terms of how we survey patients going forward. Okay, so you'll hear this over and over again, and we stress this at every opportunity that we get. The overwhelming risk factor is smoking, okay? And to some extent it is modifiable, but your risk doesn't really come down to baseline levels for many, many years, over a decade really, okay? And really the mechanism is related to what gets excreted into the urine, okay? So there's obviously toxins that are ending up in the urine, stasis of those toxins, they're sitting there, and they're in direct contact with the lining, the urothelium, and therefore they start getting damaged in some way, and this allows those cells to gain those properties that we talked about, which then moves on to low-grade cancer, higher-grade cancer, and the whole progress from there. Now, there's some other risk factors that are of interest. We hardly see some of these days. Occupational risk factors. Certainly some industries have higher risks than others. For example, hair dyes, or I guess other industries including rubber, chemical paints. Radiation therapy is an important risk factor. So a patient may have had a radiation for another malignancy, for example, rectal cancer, or maybe prostate cancer, which is a very common cancer. And by the very nature that the bladder sits right beside the prostate, it unfortunately gets a scatter of radiation. And radiation, while it's intended to kill off, for example, prostate cancer cells, it can cause mutagenic or changes to the bladder cells, and that could result in cancer, okay, bladder cancer. There's some genetic risk factors, but it is not as common. So when we look at the various causes, the environmental aspect, and particularly smoking, totally dominates, okay, in bladder cancer. And unfortunately, there's many patients that will present, and we really, don't have an answer for them when they ask, what did I do? What was my risk factor? We don't know, okay? So we don't have an identifiable risk factor in many cases. And as alluded to, and as targeted by that, public awareness ad, hematuria, or blood in the urine, is one of the most common presenting symptoms. So, and as urologists, we think of hematuria in two different ways. It's either you can see it or you don't see it. And when you don't see it, that means it's microscopic. So what we do is we have urine that's spun down, and we look at it under a microscope, and if it meets a certain amount of blood cells in the urine above an acceptable level, that raises a level of suspicion. But certainly gross hematuria, the patient has clearly seen blood in the urine. That's an alarming finding, and that's usually a very common symptom. Other common symptoms include urinary symptoms, and this can be a variety of things. And these include having to go more frequently to the washroom, urgency, which is rushing to the washroom, so a sudden urgency to get to the washroom. You really feel like you can't get there in time, and that's also common. There may be some pain with urination, or again, there may be completely no symptoms, and it's an incidental finding. So, for example, an ultrasound is done for another reason, and it unfortunately finds a little, polyp or tumor in the bladder. Okay. When you see a urologist, there's basically three things that we try to do. We collect urine from you for what's called cytology, and cytology is basically, again, a form of microscopy where we take the urine, spin it down, and the pathologist looks at it to identify abnormal cells, okay? And this is very useful, right? So, we can take advantage of the fact that the urothelium, or the bladder lining, is in direct communication with the urine, and therefore it sheds cells, and we can try to pick up some of these abnormal cells. So our positive cytology is a useful diagnostic tool, but it actually is also a very informative prognostic tool, because we can see responses to treatment and see how the cytology changes over time. Okay? The other aspect of diagnosis is from a urologist's point of view, is cystoscopy. Okay, and this is sounds horrible when you first hear about it, and it actually has come a long way from when we initially started to do cystoscopies in, I guess, the 60s, 70s. So in the 60s, 70s, 80s really as well, cystoscopy was done with a rigid instrument, and you can imagine the instrument has to be introduced through the urethra in order for us to have a good view of the bladder, and that was a bit uncomfortable, to say the least, and this was done under local anesthetic. So we've come quite a long way since then. So we use instruments now called cystoscopes, which are flexible instruments. The diameter is quite small. It would be about the size of a small pen, okay, diameter-wise, and it's introduced through the urethra. And before doing so, we usually place local anesthetic to numb the urethra, so it's more tolerable, and our patients don't need sedation, they don't need an anesthetic or anything like that. And an important aspect, and I think this is really important whenever I do cystoscopies, I always invite the patient to look. And it's very informative for us to be aware of what we're both talking about. You get to see what we're talking about. So usually the monitor is right beside, either over your head or right beside you, and will get you to look up and look at the polyp or the tumor. So you really have an idea where it is, what we're talking about, what it actually looks like. Majority of times it looks like that picture there on the bottom left, which is a little cauliflower-shaped tumor, and there's a lot of information we gain from that. How big it is, how broad-based it is, how many of them there are, and so there's actually no replacement for this. There's no way we can get as good of an image from CT scanning or MRI that could replace this. So this is a very important part of diagnostic workup. Okay. Having said that, the CT scan is still very important for us to get an idea of not only the bladder tumor, but we're interested in what's going on around the bladder, and also, as I mentioned at the beginning, what's going on above. The kidneys are still very important. The ureters, the tubes that go down from the kidney to the bladder, are very important for us to look at. So you're looking at here two pictures on your left hand there, or your right side actually, is a person standing upright, and there we're looking at the two kidneys. And here's an example of someone who has bladder cancer, but also has concomitant, or at the same time, urothelial cancer involving the kidney. So inside the lining of the kidney, they've got something brewing there, okay? On the right side is a cross-sectional image. So this is, if you can imagine, a patient lying, this is your left side, my right side. A cross-sectional image, so you can imagine a patient's lying flat, and we're slicing through them in the transverse plane. And you can see the bladder filled with contrast. So bladder is right here. Here's the bladder. This is bright white because we put contrast or dye that goes into the bladder. So this is the bladder, nice oval shape. But clearly there's something abnormal here, right? We can see that there's what we call a filling defect. This contour here is very abnormal compared to here. So this tells us a lot of information. It tells us size, it tells us what's going on outside of the bladder. We're really curious to see how extensive this is. And we're also interested to see lymph nodes in the area. And I'll talk to you a little bit more about lymph nodes a little bit later. So when we talk about staging for bladder cancer, clinical staging is different than pathologic staging. So what that means is we're trying to figure out what stage your cancer is. How deep is it? What kind of cancer, what kind of bladder cancer it is. And the best way for us to do this is to do a biopsy of it, okay? A biopsy you may have heard is called sometimes a transurethral resection of bladder tumor, and sometimes referred to as a bladder scraping. Same thing, okay? The term is transurethral, going through the urethra, resection, removal of the bladder tumor. This is almost always done under a general anesthetic, okay? It involves this time using a more rigid scope, which gives us better visualization, better control in order to go in. There are no cuts on the outside, so it's totally endoscopic, okay? Typically what happens is you go in, you have the general anesthetic, you wake up, the next day you'll have, you wake up after the procedure, and until the next day you'll usually have a catheter inside which flushes the bladder to prevent any blood clots from the procedure, okay? And we worry about blood clots because we just done an operation. We don't want anything plugging up the urethra after that, so plugging up your ability to pee afterwards, okay? So the goals of us doing this is, first of all, to remove as much of tumor as possible. So it's actually a curative procedure in many cases, as much as it is a diagnostic. So it's diagnostic, we're getting an answer as to exactly what type of stage of bladder cancer you have, but that might be the only therapy that you need for a very foreseeable future, okay? We absolutely need to recover the specimen, and we need this because we send it to our pathologist, and our pathologist takes it, they freeze it, or they embed it into wax, and they slice it up into slides and really give us really important information that directs our therapy going forward. One of the things that we do in terms of the technical aspects, yes, we want to get it out, but we really are curious as to figuring out how deep that tumor is going into the muscle wall of the bladder. And that really is the aspect that changes how we treat one type of bladder cancer, a more superficial type of bladder cancer that's more of an annoyance versus the more lethal, more aggressive kind of cancer. So that's very important for us to adequately get a sampling of the bladder. And so this is actually what we do. So you can see that this is what the instrument looks like. Okay, it's a rigid instrument. It's introduced through the penis, or in females through the urethra, which is much shorter in females, and it gives us direct view into the bladder. Okay, and what we have at the end of this instrument are these one loop. Okay, these loops are basically the instrument that we used to do scrapings with. It sounds like such a non-finesse type technique that we scrape away everything. It's actually very precise and very delicate. So these loops here, okay, you can see two of them. That these are electrocautery. They heat up. So we use electrical current, and it really lets us take swipes of the bladder and the bladder tumor to get it all out, okay? And we're able to get it all out, all the specimens out through the urethra, and there will be nothing left behind in the bladder afterwards. And so this is kind of, in real life, here's a bladder tumor, and the urologist here is taking a scraping, but really is a sweep with this electrocautery, this current, this electricity that's used to remove part of this bladder tumor, and we try to take all of that out at one setting. Okay, so this is an important slide. So I'll go through this slowly. When we look at pathology, so pathology is the specimen sent to the pathologist, and they give us a report back, and in that report they tell us two things that we're interested in. We're interested in grade, we're interested in stage. So the grade is really the culmination of what the pathologist was really trained for many, many years, and is reading this report based on a lot of consensus and guidelines based amongst many pathologists, many uropathologists, and what they're looking for is features of those cells that tell us that it's more aggressive or less aggressive. And they used to, in the past, give us a number from 1 to 3. Nowadays, they typically give us a high grade or a low grade idea. Okay, so high grade obviously signals more aggressive tumor. It has features that make it more lethal, more biologically lethal. This is the kind of cell that can more likely escape the bladder, can spread. Okay, versus a low-grade cell, it doesn't have the potential usually to be a bad actor. The other aspect is depth of penetration. So that's what we mean by stage. So how deep does it tunnel into the muscle wall? And there are different layers to the bladder, and that's why it's really important that we take a good piece of the bladder out transurethral, so through the scraping. And this helps us really categorize bladder cancer into two groups. Okay, the first group is non-muscle invasive bladder cancer, and muscle, okay, is this layer right here. Okay, now it's really impossible for us to draw a red line here or a black line. It's never black and white. There is a group of patients that lie right here. Okay, and that's where kind of the nuances and direction you take from your uro-oncologist comes in. But for the most part, most of these tumors that lie on this side where the muscle isn't involved behave very differently than these tumors here where they've already started to invade deeply into the muscle layer. Okay, they can go even further into the muscle or potentially outside of the bladder here, or they may already be involving an adjacent organ. And so here's an example of an adjacent organ. I'll show you some basic anatomy pictures in a little bit, but here's a prostate that's been involved. The prostate's sitting right beside your bladder in males, so that's an important prognostic tool for us. So all of this is used, all this information is used for us to match the aggressiveness of our treatment with the aggressiveness of the tumor. So that's our whole philosophy. Obviously, that's the tumor aspect of it, and then the other aspect is, patient factors, your preferences, and how your medical health is overall as well. Those are really important aspects for us to consider. So, for the most part, when we look at non-muscle invasive bladder cancer, we tend to break these up further into two groups. There's the low-risk type of non-muscle invasive bladder cancer. These are the low-grade tumors. These don't go deep into any of those layers that I really showed you. And these are more really of an annoyance. These are basically often mean repeated cystoscopies in order for us to continue to survey the bladder to make sure nothing pops up so that we can control any of these polyps as they arise. Unfortunately, there is a risk that these might progress, but the risk is low. So what I mean by progression is that these might, in the future, turn into something that goes deeper. And so, that's the reason why we'd want to keep an eye on things, keep things in check, okay? But for the most part, they're not really a threat to life. There's another group of higher risk bladder tumors that fall into the non-muscle invasive bladder tumor group, okay? And these have features like high grade, so they look very abnormal under a microscope. They have, they have other pathologic features, something called carcinoma in situ, which is a poor prognostic factor. Or they may be going into a layer that's a little bit deeper, but not quite the muscle layer. And so we worry a little bit more about these patients. We worry about them because they can progress. So that means that over time, these are the patients that we have to be careful about because their tumor can change, they can penetrate deeper, and they may warrant more aggressive therapy down the road. Okay? So the understanding is, hey, we can start off with this course of bladder preservation right now, save your bladder. We have various modalities that we would use for non-muscle invasive bladder cancer, but the real understanding is that we have to be ready to pull the trigger on something more aggressive should this tumor start to change. Okay, and you'll hear about BCG. This is a vaccine that's actually not widely used. It's used for prevention for tuberculosis. It works relatively well, but the interesting story is actually this vaccine was being initially used to treat melanoma. So it was causing your body's immune system to be revved up to fight melanoma, and a urologist in Kingston, Ontario had the idea of trying to use this for bladder tumor and place it into the bladder. So that's not chemotherapy in the standard fashion that we give it through the IV. So this is called intravesical therapy. That means we deliver it right into the bladder. So you get your bladder filled with a dose of chemotherapy. It sits there for a bit, and then it's drained out. And so what this BCG vaccine is doing is that it revs up your immune system, okay, locally. And we know that the immune system is a very important aspect of controlling cancer. And in fact, what it seems to be doing is turning on the immune system to fight the remaining tumor cells that might be there, thereby preventing recurrences, preventing the tumor from coming back. Okay? It's very effective. Your urologist will say, well, we're going to start with a course of BCG, which usually means a six-week commitment. So you come in, unfortunately, once a week for 6 weeks. That's the first part. And depending on how aggressive and how at risk you might be, the urologist might give you what's called maintenance BCG, which is once a week, and the duration of that can vary from 1 year. Okay, so once a week every month, then every 3 months, every 6 months, it depends. The schedule's a little bit different, but the total duration, okay, while you're not seeing the urologist every week for that amount of time, the total duration that you might have BCG is over 3 years, okay? It can be quite a long period. And that's varied based on how the patient responds to BCG, how they tolerate it. There's a lot of things that change about that. But BCG is really a very important aspect of how we manage these higher risk patients with non-muscle invasive bladder cancer. Muscle invasive bladder cancer is a completely different entity. This is a lethal cancer, and of all the cancers that we treat as urologic oncologists, we worry about bladder cancer the most. So when bladder cancer starts to invade the muscle, really starts showing signs of going outside of the bladder, it is extremely lethal. And unfortunately, over the last 3 decades, we really have struggled to really show that we can change the course of muscle invasive bladder cancer. And we're struggling with that. Right now, when you have muscle invasion, the best and the gold standard of treatment is radical cystectomy. Okay, full stop, period. I think that it's really important to not take this as, you know, my word that it is the only form of treatment. By gold standard, I mean that it has the most weight of evidence that supports it of all the treatments that we have. It's important that we continue to look at other aspects of treatment for muscle-invasive bladder cancer, and there are certainly novel approaches that are coming too, and there's mounting evidence and good evidence, but I would still say the gold standard is for the bladder to be removed, okay, and for some sort of reconstruction to get the urine out in some way, and we'll talk about that in detail. So when we talk about removal of the bladder, it's a big procedure. I'll detail the details of that in a little bit. But part of this gold standard that I've said to you is actually also chemotherapy. So chemotherapy in bladder cancer can be given at various stages. Okay? Most people think of chemotherapy as being given, you know, when things are not curable, when we're at the last stages of life, unfortunately, where the cancer is terminal, and this is totally not the case in bladder cancer. Okay, so we may have many patients with muscle-invasive bladder cancer where the tumor is still in the bladder, where we give neoadjuvant chemotherapy, where we send you to a medical oncologist to give you chemotherapy before the surgery. Okay, and there are really two reasons that we do this. The first reason is that we try to shrink that tumor, get it down, get it to respond, so that it makes our lives, from a surgical point of view, much easier. It makes the surgery easier, where we anticipated that the tumor to be really big and growing deep in. We might find that once the bladder is out, it is not as aggressive, it is not as deep, because you've had a very good response to the chemotherapy. Okay. The other aspect is that, you know, in 2016, our limits of imaging are that we can only see lymph nodes and cancer cells that are about a centimeter, 5 millimeters, that size. So we don't really know what's going on microscopically. And so what this chemotherapy up front and right away might mean is that we're actually delivering treatment to kill off microscopic amounts of cells that have spread, that have escaped. Okay? And the biology and the rationale seems reasonable, but we actually have good evidence when we take a group of patients and put a group through neoadjuvant chemotherapy and surgery and compare them to a group that just had surgery alone. We know that they have better survival. So there's good evidence to show that this works. Okay? So many urologists will recommend this up front. This is not, I'm not going to say that everyone should have it. We try to get it to most people. There's some groups of oncologists that feel that there's, you know, particularly higher risk patients that definitely need it, others that we might not see the same benefit. And chemotherapy is not totally benign, right? So it's, again, a discussion that you have to have. You might have certain features, medical conditions that may not make you suitable to get chemotherapy. So while we'd like to try to get you to chemotherapy, it might not be feasible, okay? And the timing is usually you go through 3 cycles of chemotherapy, then we do more imaging, and we see what kind of response that you've had. If you had a good response, we complete the 4th cycle usually. If not, we may pull the trigger earlier and go straight to surgery. So I think sufficient to say that I just wanted to lay out that radical cystectomy is the gold standard. We'll talk about how we do it in a little bit. Neoadjuvant chemotherapy is a really important part of that whole process. Okay? There are very important therapies that are coming out now where we're looking at ways that we can preserve the bladder. Okay? Obviously, that would be the ideal scenario for quality of life. As long as we can't compromise cancer control, that's a reasonable approach. And what we do in that scenario is the main thing that we do in this scenario is to make sure that we've removed all the bladder tumor that we can see endoscopically, okay, so with the scrapings. Then we usually work with our medical oncology and radiation oncology colleagues to deliver a multidisciplinary or multi-team approach to chemoradiation. So radiation therapy to the bladder together with chemotherapy at the same time. The chemotherapy is a totally different type of chemotherapy. And we follow you very, very, very closely because at the moment that you show that you're not responding to the radiation or chemotherapy, we have to be ready to pull the trigger. And that's really important because this is kind of a transitional phase of this new therapy. While we have very good groups in North America that have done this very well, the point is that we just can't do this in blanket. We have to keep an eye on the patient very closely. Partial cystectomy, that means removing only part of the bladder and preserving the rest of the bladder. This can be only done in very select patients, and it's quite rare for that patient, for us to actually find a patient that we can offer this to. So as I said, radical cystectomy is a gold standard. In males, it involves removing the bladder, which is right here. It involves removing the prostate, which is immediately adjacent. The reason we remove the prostate is twofold. The main important information that we get is that actually the bladder tumor may invade into the prostate, and from a technical point of view, the reconstruction is much easier if the prostate is removed. Okay, at this point, usually, discussions regarding fertility and things like that are not relevant in this group of patients that we see. So we remove the prostate, remove the bladder. Okay. In women, the operation is often called an anterior exenteration. So, big name. All it means is removing, unfortunately, many of the organs that lie in front of the rectum. Okay. So here's the rectum, here's the vagina, here's the uterus, here's the bladder. So in women, the operation is much more involved, but it actually, while it seems like there's a lot more involved, it's actually not that much more surgically involved. So we remove the bladder, the uterus, part of the vagina here, reconstruct things. In women who desire fertility, obviously, in women who are still wishing to preserve sexual function, we really have an important discussion about organ preservation. In the select patients that have the right tumor, certainly feasible to modify this surgery. One of the most important parts of radical cystectomy, that is removing the bladder, is not just removing the bladder that after we remove the bladder that we do a lymph node dissection. So here's a picture of a human pelvis. Here's the bladder right here. Here are the two tubes, one tube, second tube, those are the ureters, right? So they're draining urine into the bladder. And these are the big vessels that are coming down from your heart. So this is your aorta coming down, splitting up and going to your legs, which one leg would be here, the other leg would be here. And here's the big vein that drains your legs, your pelvis, and goes back to your heart. So that blue is the vein, the red is the aorta. And you can see these specklings here. This is these things here are lymph nodes. And this is actually a mapping study where they've mapped where cancer spreads from the bladder to these lymph nodes, okay? So it's very, very important that we take out these lymph nodes to sample them in order for us to get an understanding of cancer stage, okay? Moreover, not only is it important for us to sample them so that we can tell you where the stage is and get an idea of prognosis, but it actually might be helpful in terms of survival. So removing these lymph nodes that have cancer in them actually will help control the cancer. It makes sense, right? So most of the evidence points towards that. And how many we remove and all that is actually a very, very important part of bladder cancer surgery. In fact, probably even more, some would argue more important than removing just the bladder. Okay, this is a really important part of the surgery. The other aspect, and we'll spend a bit more time on this, and this really impacts your quality of life after, is what we do with the ureters afterwards, right? So you've disconnected the bladder from the tubes that are draining the urine from the kidneys. What do you do afterwards? How do you get the urine out? And there's really two ways to think about it, okay? And this really takes a discussion where we talk about what your goals are, what the cancer prognosis is, what kind of implications this has for your social life, your quality of life, all that you need to know up front. But you also need to appreciate the complexity of each of these diversions, because the more complex it is, it means that it can need more work down the road. Okay, one of my mentors always says, do you want the Honda, which is more reliable, never in the shop, or do you want the Maserati, which is always in the shop, you need revisions? Okay, so we laugh about it, but it is really, because we know when we look at these patients in the long term, we unfortunately have to go back, potentially surgically. We may have to do endoscopic procedures to correct issues with these. So we want to match you to the best quality of life we can offer, but with the understanding and very tempered understanding of what this really means. Okay, so the two things that we want to address is: do you want to have a continent? Do you want to be able to control when you want to empty the urine, or do you not want to have control of that? Okay, and the standard and the longest standing, the most simplest way of getting the urine out is an incontinent diversion called an ileal conduit. All that is, and I'll show you pictures to explain this further, is a simple way to bring urine right to a bag, an appliance that you wear on the surface of the skin which collects the urine, and then you simply empty that bag every 4 hours, and perhaps wear a larger bag or connect it to a larger connection or collection bag at nighttime. The more complex diversions, so these are the Maseratis, so to speak, include a neobladder, which means new, bladder. So there's a bladder that we reconstruct using bowel and connect it to the urethra so that you pass urine normally, and we connect the ureter to that, so you fill the neobladder with urine and then you void normally. But I'll tell you right away, and your urologist will tell you right away, voiding with the neobladder is completely different than voiding with your regular bladder. You don't have the same sensation, how you void, all that you need to understand up front, okay? You need to also understand now there is, we're aiming for continence, but your continence is going to depend on how well your muscles control the urine after surgery. And that everyone can vary. Early on, it's going to take time for you to recover those muscles, and these are things that we have to talk about. So while we're aiming for a complete control of the urine, the first few months or longer could very foreseeably involve having to wear continence diapers or pads before we get you to a point where you can completely control the urine, okay? So that's really important. The other diversion I'll talk about is a continent catheterizable stoma. I'll show you a picture so I can better explain that. So this is the Maserati, the Cadillac, whatever you want to call it. So this is a neobladder, and the way that we create this new bladder is we take a long segment of bowel, your small bowel, okay, and there are consequences to removing that bowel. Most people do just fine with that amount removed, but we'll talk to you in detail about those issues, okay? And then we reconstruct and reconfigure that bowel so that we get a nice spherical shape. And that shape, basically grows over time, and that new bladder is reconstructed and connected to the urethra. So this is the urethra down below. So there's a urinary passageway on the way out, okay? And you can see here the two tubes from the kidneys filling this, okay? You can imagine after your cystectomy, doing this takes much longer for the surgeon than would be to simply take a tube of bowel and bring it to the skin surface. So the operative complexity is much more, and therefore there's more likely issues that you could have afterwards, okay? And I'll talk to you right now just to tell you, for example, what could happen afterwards that you need, okay? Well, maybe your control of the urination in the long term never gets to a point that you find socially acceptable, that you find is a reasonable quality of life for you. And so maybe you might need a procedure to control your sphincter, to control your urine flow better than you can with your natural muscles. So that's another procedure down the road, okay? So that's very important. The other aspect that we would stress is every patient's different, but there's a chance that you might need to catheterize. So you might need to take a tube and pass it through the urinary passageway into the bladder in order to drain it. And the risk is different for everyone, but you have to be prepared for that, okay? So this is another way that we can get you to control the urine and be able to empty the urine when you're ready, okay? So this reconstruction is a little bit different in the sense that we use large bowel. We fashion it in a little bit different way. And the way we do it is we make a pouch, but instead of connecting the pouch to the urethra, so your normal passageway, what we do is we bring a little stoma, but a much smaller stoma. And a stoma is just the opening of the bowel to the skin. And we put this stoma in a hidden place usually at the umbilicus, okay? So it's maybe not very obvious on the outside, okay? And so what you do as the patient is that over time you develop a sensation of when the pouch feels full, and you'll simply go to the washroom discreetly and pass a tube through that stoma, through that little opening, okay, into the pouch and drain the pouch out into the toilet or into a container, okay? Again, more complexity, there's chances there, certain components of this need to be addressed down the road. So anytime that you add complexity, the chance of having to go back in, meaning to do a revision, for example, for us to fix something that's not working exactly well, is a little bit higher. So again, you have to talk to your surgeon about the details about all of this. I won't get into the fine details, but just to keep that in mind overall. So while this, it's a great option in many people, you have to be aware of what your expectations are should be, okay, in the long term. Okay, so this is the ileal conduit. Here's a picture of a piece of bowel that's been isolated. So we take a small piece of bowel, about 15 centimeters, okay? We take it away from the continuity of the GI tract, so that means that your food goes back through the same pathway. That's undisturbed. And then we take this segment of bowel, bring it to the skin, and create a stoma. This is what a stoma looks like, okay? And the stoma is, we spend a lot of time planning the stoma. We have, obviously Debbie's going to talk to you in a little bit about this, but this is very critical where we talk about where to put it, because that's going to be an incredible, important determinant of your quality of life afterwards, okay? But there's a lot of planning that still goes into it. So whereas it's very straightforward in terms of the surgical aspects, there's a lot of things we need to talk about where we put it, how you'll manage with it, that will be important, okay? But from a revision point of view, having to go back and fix things later down the road, this tends to be the most reliable form of getting urine out, but obviously the drawback is, at least the perceived quality of life difference, okay? So I want to shift gears now. So I want to really focus on minimally invasive approaches to treating bladder cancer. This is what I'm really interested in. As you know, bladder cancer is unfortunately, we get this double hit. So we have this really lethal cancer, but unfortunately we see it in our patients that are at the latter stages of their life, where they unfortunately have higher medical comorbidities than the general population. So here we've got a group of patients that need aggressive therapy, but may not at the same time tolerate such a big surgical procedure. And so we've seen minimally invasive approaches to do the same surgery really come into to the market and to come into medicine for a lot of other cancers, but we really have only starting to see this for bladder cancer surgery and for radical cystectomy over the last decade. So I want to talk to you a little bit about that. So what is minimally invasive surgery? So minimally invasive surgery is basically synonymous with keyhole surgery. So instead of making a traditional incision from your belly button down to your pubic bone in order to get at the bladder, what we do instead is to make a little incision, put a 1 centimeter size port in, and so this is a port, okay? So this is a little device that goes in through the abdomen into the belly. And then what we do is we blow the belly up with carbon dioxide, fill it up like a big balloon, okay? Now you're all asleep and someone's giving me some weird looks like this has got to be painful. And no. So the reason we're doing this is to create an area, a space for us to work so we can see everything. You can imagine this first started in the simpler procedures, right? So we did this for appendectomies, we did this for gallbladder. So you would never see someone getting a gallbladder or an appendix out nowadays, and I'm pretty sure it's never without laparoscopic surgery. So that is now kind of standard of care. And so, as with technology, it starts to diffuse. We start using it for other approaches, and it's slowly it first made its way into prostate surgery, but here's, what we're doing for bladder as well, okay? So what we do is we put in a little 1 centimeter size port. We fill up your abdomen with carbon dioxide to give us that space, and so we then put a camera in through one of these ports. So we use a little camera, about 1 centimeter in size, and that lets us view what's going on a television, okay? So we're able to now see inside the belly and inside the abdomen and see where we need to work. So in order for us to do work, to manipulate tissue, to do what we need to do, and remember we have to do everything that we did in terms of open surgery with using our hands. Now we have to do this with these instruments. We need to put other ports. So what we do is we put in a series of other small little dilating cannula. So all these are tubes that go in through the abdomen. They go through the muscle and they go into the belly, and it allows us to exchange instruments and different instruments for us to be able to do the kind of work that we need to do, okay? Everyone's so far so good, okay? Laparoscopic surgery. But the tough part about laparoscopic surgery is that ergonomically it's terrible, okay? So you can see here's a surgeon that looks completely awkward in trying to do what they're doing. It's very difficult. It's your hands are in the air the whole time. You're trying to replicate what you would do normally in open surgery. So it's a bit more challenging, but we with learning and with experience, that can be easily overcome. But what makes laparoscopic surgery very difficult is the fact that there's no articulation. So these instruments, and here's an example of a laparoscopic instrument that we use all the time. Okay, these instruments don't have wrists. All they do is open and close. So they're scissors. Okay, so imagine operating with a long pair of scissors. That's all you have. Okay, so the dexterity of laparoscopic surgery hasn't really been there for bladder cancer surgery. Okay, bladder cancer surgery is very different than removing an appendix, than removing your gallbladder, okay? It takes a lot of finesse. It takes, you need to be able to do the operation in a reasonable amount of time to gain those benefits of those little incisions, okay? And so what's really changed in the last 10 years is robotic surgery, okay? So robotic surgery, the key innovation with robotic surgery, and I'll talk to you about what robotics is in a little bit, is creating instruments that have a lot of dexterity. So not only do they open and close at the tip, but they have a wrist just like the human hand that can give us full total rotation and movement. So essentially, it's like as if you had your hands inside and you could do and replicate the same things that you would do with open surgery, okay? And so we're going from two long instruments that open and closed to a totally different system that can articulate, totally move around. And so that's just completely like a wrist. And so you can see here, a surgeon is suturing, and they can direct the needle exactly where they want to put it, turn it, push it through. And here's the surgeon at the bottom aspect controlling the instruments from far away. Okay, so they're in the room, but at a console controlling the instruments. So what controls the instruments is this big robotic device. So basically what's happening is while the surgeon's at a console looking inside and operating, okay, there's a robot that's controlling these instruments. So the robot, go ahead.
Do you use this?
Yeah, we use it at the Toronto General, Toronto East General.
You know how to drive this machine?
Yes, it's actually very straightforward.
Wow.
I bet you, it's very intuitive. So the robot, okay, it's not a robot. It's a master-slave unit, okay? So a robot is an autonomous thing. It does something that's programmed to do. It makes decisions. It does maybe in next century surgery on its own. This is a master-slave thing. So your surgeon uses this device to control the arms, okay? The surgeon is in complete control. It doesn't do anything on its own, okay? But what it does is it gives the surgeon much more dexterity, okay? And that's what's revolutionized minimally invasive surgery over the last 20 years, okay? So here's this robot, okay? All it is it controls these laparoscopic instruments, okay? What happens is the patient is put to sleep. We fill the abdomen with carbon dioxide like we usually do, and then we put in all those little ports, okay, for us to be able to put instruments in. But instead of the surgeon sitting beside the patient and introducing these instruments, what happens is this robot is attached to those ports and it controls those instruments, okay? And usually there's a bedside assistant, another surgeon that's sitting beside the patient, exchanging those instruments, maybe putting additional instruments in to help as well, okay? So that's how it all works. The surgeon is really lucky in the sense that they get to sit down for the operation. It's a much, I joke about this a little bit, but it actually is a much more ergonomic operation. You sit down, but it's not just that. It's what's changed is you can imagine looking at a video camera inside the belly, inside the abdomen. What you do is you get a 2D image, right? So we have no idea how deep things are. And so we were at a total loss for this. And what this system has done is given us two cameras and brought those together. And so, in fact, we have depth perception when we sit down. So that, together with the dexterity of the instruments, really allows us to do, quite a bit more with bladder cancer operations. So, in 2003 was the first real description of robotic cystectomy. Okay. And that was done, I believe, in Detroit. And since then, robotic cystectomy has really exploded. Laparoscopic and robotic cystectomy has really, I wouldn't say exploded, it's steadily increased. So in the United States, if you look at the total number of cystectomies being done, I would say about 10 to 15% are done robotically now. The rest are done open. And depending on which center you go to, that number varies. So where I train, it would be 50-50%, okay, robotic and open. And not only can we do it robotically, we can do the whole process. So not just removing the bladder and the lymph nodes, but do the whole reconstruction. So meaning take the bowel, do our bowel work in order to create a neobladder, in order to create the type of urinary diversion that's needed entirely robotically. So that's a really important thing to appreciate, because that means we're doing the whole operation with these small little incisions, okay, and then one of the incisions made bigger in order to remove the specimen, remove some of the things that we need to take out. But we really are hoping that this is going to translate into better length of stays, quicker recovery, quicker return to work, quicker return to function. But more importantly and fundamentally, we want to minimize the amount of surgical stress on these patients who have lethal disease, in whom we want to deliver really good surgery, good control, but also want to get them through surgery without any hiccups, okay? And that's really important. And so let me just run through an unedited video right now. Just so I'm not going to go through all of this because it's a little bit bloody here. So in case you're not used to seeing this, I just want you to see what it's like, okay? So imagine, up till now, we used to make incisions and we look inside from above the patient and look deep into the pelvis. And the pelvis is a deep-seated organ, right? Like all the organs there are deep in the pelvis. So we have to wear headlights, we wear magnifying glasses in order to do our surgery as open surgeons. That was tough, that was difficult. But now we have much better view of exactly where we want to be, a much precise view, and these instruments are extremely precise. So here's a surgeon doing exactly what we would want to do in open surgery, but doing this robotically. And I just want to kind of tell you, I really mean that the kind of view that we get is unparalleled, okay? So you wouldn't believe this, but this is a view that we would hardly ever see in open surgery. Okay, I can't imagine ever having this kind of view when we do open surgery. But we can look right under the bladder, we can look above the rectum, and that's what's really exciting about this kind of approach, is the view that we have, how detailed it is. Just let it keep on playing here. And here's, the robot has extra arms, so it's, you're moving one thing out of the way, but you're able to operate very precisely. So, as I said, we can do every aspect of this robotically, and in the past we used to just take out the bladder robotically and then make an incision and do the rest of it by open surgery, but our feeling is that that's not maybe the best way to go, that there may be an advantage, and we think there's an advantage in doing everything robotically, and that's the way that we're kind of moving forward. And so here's just a few pictures. You don't need to understand exactly what's going on in each of these pictures, but to show you that in these pictures we're basically showing different steps of how we create a new bladder, but all of it's done, all the bowel work, everything, measurements, and all the work is done inside the belly. So here is the robot, the surgeon working on the robot. We've attached here the bladder, the new bladder that's built out of, so here we're looking at the pelvis again, okay? Here's the urethra down here, okay? Obviously the bladder has been removed, and this patient wanted to proceed with having an orthotopic neobladder. So a neobladder made out of bowel has been reconstructed, and we've already connected it, and we're just finishing it. So you can see the appearance of a pouch here being connected and finished off. So you can see here the surgeon is just finishing up the sewing. Okay. So just give you a sense of what I mean by robotic surgery, robotic bladder cancer surgery. I think it's really important to see those videos and to get an idea of that. Okay. But the question really is, we have to evaluate where we're going, whether it's actually better, whether the outcomes are better as we move forward. And when we think about robotic surgery, we have to compare it to open surgery. And we like to compare it in terms of, can it do the same things? Sure. But does it reach the same cancer goals? Does it reach the same functional goals, meaning do the patients still have the same outcomes in terms of controlled urine? All that is very important. We also are really, really interested in seeing how they do over the first 30 days after their surgery. What kind of complications do they have after in hospital? Do they use less pain medications? Are they able to get up and walk sooner? Do they pass gas sooner? So the operative time, as I mentioned, seems to be lower with open surgery, okay? But the key advantage that seems to be coming through more and more is that blood loss is much lower for robotic surgery, okay? We're finding early on right now the complication rates, depending on who you look at and where you look at, are about the same. So for us, this is really important, right? This is what drives bladder cancer outcomes early on, okay? Bladder cancer, as I said, it's pretty morbid surgery. About 30% of patients will come back to hospital in the first month after surgery, okay, for a variety of different reasons. And anything that we can do to minimize those complications are critical. And this is, older data, but right now we don't have very good evidence to say it's clearly, head and shoulders above, okay? But, length of stay, okay, seems to be a little bit more in favor, okay, but not always. In terms of robotic surgery. The thing that we found is that in some of the studies thus far is with robotic and laparoscopic surgery, patients may be able to pass gas sooner. So what does that even mean? One of the biggest impediments to your recovery after this big surgery is how fast your bowels recover, okay? Anytime you manipulate or even touch bowel, let alone cut into it to do all this stuff, all this fancy stuff to it, your bowels somewhat go on strike. They get stunned and they don't wake up for a while. And that's called ileus. And that ileus can last anywhere from a day to 5 days, and everyone's different. But what we think is that the less manipulation, less handling, less exposure to the air, less stretch on these bowels, patients might recover quickly, be able to eat, get up, start moving. And that really, I think, is going to be an important driver in being able to get patients home sooner, okay, to recover sooner, to get home sooner. I already mentioned that quality of life is very comparable so far, much more to be done. And the data is very early on right now, and I'm not going to go through this in detail, but it's important to realize, and we're tracking this closely, we need to be able to be sure that when we offer this to patients that we're doing a good cancer operation, because fundamentally, that's what we're trying to do, to provide cure. And so far, from every metric that we have, everything seems to be pointing in that direction, and more data is needed. Okay, so we're still in our early days in robotic surgery. So just to kind of recap, what I wanted to stress was that bladder cancer treatment is really tailored to the aggressiveness of the tumor. I think robotic cystectomy is certainly, going to be a very important player. I don't know if it's going to be the most dominant player, and the question in Canada and the United States is a bit different. I think I've tried to convince you a little bit, at least. There's no question that robotic surgery is the way that we're going to do surgery in 20 years. There's absolutely no question in my mind that's how we're going to do surgery, okay? Just to give you an idea of how far we're moving in this, when I trained as a resident in Canada, in Toronto, we did open surgery for prostate cancer, so we did open prostatectomy. And when I went to the United States to finish my fellowship training, I didn't encounter a single resident that knew how to do an open prostatectomy anymore. The training is completely changed. Some of it's been driven by market forces. We have to recognize that. But it's also, we're here now in terms of robotic surgery, but I also think that there's a lot of advantages to the system. The way we move forward in Canada, I haven't touched on how we move forward in Canada, how we kind of balance the costs issue, and really how do we find value, right? I think that potentially bladder cancer surgery is one of those surgeries when you look at robotic surgery, it's one of those surgeries where if we can really show good outcomes, really much better outcomes than open surgery, it might be, the value might be there for us to really support it and move forward. And in terms of the future, and I mentioned this a little bit, we sometimes get caught up in technology and approaches. Radical cystectomy is the standard of care for muscle invasive, but there's a lot more to be done. As I said, the mortality, when we look at mortality from bladder cancer, has really not changed. It hasn't changed in about 30 years. So we're not really shifting the needle. And so I think the next 10 years we're going to see a lot more personalized medicine, personalized oncology. And so the idea here is to get an idea of your sequence, your genetic sequence, your biomarkers, the tumor's biomarkers, and really tailor therapy. So, are you the person that's going to best respond to chemotherapy? You go that direction. If you're not, you go straight to surgery. The other aspect to consider is immunotherapy. So in oncology, we have these pillars. We have the pillar of surgical oncology, we have the pillar of radiation oncology, we have the pillar of medical oncology, and it's quite clear that the next pillar is immunotherapy. So the idea is, how do we rev up the immune system to turn itself on to attack the tumor cells? And we've seen some remarkable new agents that are in clinical trials that have actually succeeded in also clinical trials for bladder cancer, that are particularly for advanced bladder cancer, but have had really important results. So we're going to probably see those being shifted earlier and earlier in the disease process. And certainly there's some important trials going on a debt for that. But I think those two areas are very important moving forward. Thank you very much.